Thank you, Patrick, for the very kind introduction. So, I'm going to talk a lot today about a deep love of mine, if I can get the slides to advance. There we go. About how we think about interpreting lab tests, which is something I've been obsessed about for a long time since I kind of first really started to learn about lab testing from a kind of statistics background. But to start with, I have no relevant financial disclosures, but some of the methods I've developed are under provisional patents, particularly some of the stuff from my time at Harvard system, which is, I think, pretty aggressive about patenting things. So I'm going to start with something really basic mostly for this audience, but I think it's a good framing thought, which is just briefly talking about the complete blood count. This is a room of pathologists, so most people are going to know a lot about this test, but for those who don't, it's the most commonly collected blood test in the world. It's the thing that you get anytime you walk into the ER. If they're evaluating you, you get daily in the US in morning draws as an inpatient. It's the first thing you get tested as an outpatient when you go for a yearly physical. And what they're doing, they're taking a sample of blood, centrifuging it, separating it into its constituent parts, and top line, they're reporting cell counts. So how many platelets, white cells, things like that, from usually flow cytometry. There's actually a few other ways to do this. There's some fun computer vision systems that have been patented and brought to market and then failed, but most of the tests are flow cytometry. And then second level of that test is some general characteristics of those cells. So things like the average size of the red cells or their average hemoglobin content, which again is derived from flow cytometry. And I'm not really going to talk too much about this, but I want to start with a framing thought, which is we have this complex flow cytometry data from a test that's run about 1 billion times a year by back-of-envelope calculations. And so we're estimating some of the most plentiful cell types in the body, taking single-cell measurements of tens of thousands of cells, and currently the most complex thing we routinely do with this data, that again is collected not just here, but in all sorts of settings across the world, in some of the most resource-limited healthcare settings, we still have this data. The most complex thing we do with it is look at the average red cell size. And that is a thought that kind of drives me insane, because I think there is just so much we can do. And to give a brief example, this is not really going to be the focus of the talk, but I think it's a good frame. This is some work from Amber Chen, a PhD student in my lab. This is what the CBC looks like under the hood. A bunch of different channels of flow cytometry, from things like your basic CBC on the left, your white cell differential, or platelet or reticulocyte testing if it's ordered. And you can mine that data to develop novel biomarkers that are telling you unique things that are meaningfully different from the current CBC or differential markers, and that are prognostic for specific diseases or general patient outcomes. This is mostly unpublished data, but coming very soon. Amber's going to get me another draft of the paper this week, I think. So, but to maybe take a step back, this is a true across medicine. This isn't just a CBC problem. Basically, all medical tests, when we drill down, are physics devices or chemistry devices generating a continuous data stream. Not always being captured that way, but that's what's happening under the hood. And we have things like a lot of coag testing uses light transmittance through a clot as it forms or dissolves and generates a transmittance curve. We don't use the full curve, we use a single point on it, or maybe 2 points on it. We have EKGs in cardiology that have really continuous dynamics. We have things like continuous glucose monitors in outpatient settings. We have one of my favorites, spirograms from pulmonary function testing, where we mostly just look at how much you can breathe out in volume in 1 second, as opposed to the actual dynamics of the curve. Or something like cycle thresholds from PCR testing. Some of these have a little bit more saturating use these days, but a lot of the data we collect, we just don't even look at, even slightly. And this is kind of the thought that sits in the back of my head. And so it's not what I'm going to talk about today, but I wanted to start with this frame, which is that we don't use even a small fraction of what we collect. And there's some really valuable signals in there. But what I am going to talk about is the things we actually do collect. So let's go back to the CBC. You take your test results, you'll say white cell count. And The first question we're going to ask is, well, what do we do with that? It's not a purely diagnostic test like, say, a PCR for a specific, say, COVID rat test, trying to test positivity for a very specific disease. It's a general physiologic marker. So how do we interpret what that means? And again, this is a room mostly of pathologists who know the answers, but I think it's worth taking a step back to the patient perspective to go, for a lot of patients, if you're in an outpatient setting, you go to your physical or a checkup, you get your test, you see your results, this is really the only vaguely interpretable window to your health, right? It's freed from the huge amount of jargon that's going to be in the report that your doctor writes. And so this is the way you can understand what your results mean. And you maybe don't know what these markers mean or only very vaguely. And so what you see is a green bar, and you see your results somewhere either in or outside of that green bar. And green means good, green means go. Yellow or red means not so good. So that's basically the starting point. And I think if you're quantitatively minded, the first question you might ask is, well, what does normal mean? And if you're a statistician like me, you will start to really question what normal means. And so again, rheuma pathologists, so most of you will know that when we talk about a normal range for a test, what we're typically talking about is a 95% confidence interval of the values in a healthy population. So we go out into the general population, get a bunch of samples, look at the middle 95%, or sometimes this will be one-sided if the test is from, say, 0 or lower limit of detection through to some high value. It might be age or sex specific, though often isn't. And so normal is just, well, here's a healthy population and against. And this kind of makes sense as an idea, okay, reference against health, but when you start to think a bit more about it, I think it has some key big challenges with it. The first is it's not a very physiologic way of looking at data. It's not trying to tie to a diagnosis or a decision. It's referencing against health, which another way of framing that is it's very good at detecting health. It's not actually very good at detecting disease. It's also training us to think about the data in a low granularity way. Yes or no, good or bad. Now, obviously, doctors think about dynamics of patients. They think about the quantitative numbers, but this is pushing us to try and think about it in a more simple way, which I think is not helpful. It's also not context specific. We use the same reference intervals for a lot of tests in inpatient care, in different disease settings, in the ICU, as we do in outpatient medicine, despite the fact that what we would consider a normal value for most tests is drastically different across those settings. And finally, it's not patient specific. I have my own set of genes and gene environment and interactions that have informed how my body achieves homeostasis and what that looks like. And my homeostasis is different from your homeostasis, but we don't really account for that. So a lot of my research and the things I spend my nights thinking about span these kind of 4 buckets. But before we even get there, I think we should take one more step back and think about how do we even measure or construct a reference interval? I think this is particularly relevant for the department given the transition to Roche instruments in the clinical chemistry lab that's going on right now. So let's talk about how we do that. So if we go to CAP or CLSI guidelines, so governing body guidelines, there's 2 big buckets for dealing with reference intervals. You can either establish one if you don't have one already. Say it's a new assay you've developed, LDT or such, or you really just think there's no prior standard, or you can take an existing reference interval, say for a slightly different device or different population, and verify it in yours. And CAP will say that to establish a reference interval, you have to take at least 120 healthy individuals, healthy usually meaning you screen them, ask them about their disease states and comorbidities, etc. And then you can calculate limits either parametrically, which means you say calculate the mean and the standard deviation and extrapolate out what that would make the lower and upper percentiles, or non-parametrically. Line your data up from smallest to largest and find out where the cut points are. And if you only want to verify, it's a lower standard of evidence, so they say you only need 20 individuals, and if no more than 2 of the 20 results fall outside that reference interval, it's considered verified and fit for use. And I'm going to start with an old man yells at cloud moment, or a not so old man yells at large cloud, which is that this is kind of the equivalent of building a house on sand. It is absolutely garbage and has no grounding in any good understanding of statistics, if I want to take my really inflammatory version of that statement. But let me try to back that up. Let me convince you of that. Well, where do these numbers actually come from? Where do the 1, 20, and 20 arise from? It turns out you have to dig a lot to find it. The 120 that CAP and CLSI use is from one paper from 1971, and all that paper showed was that 120 is the smallest number of samples for which you can stably calculate a 90% confidence interval on each bound. So I can say my lower bound is, my lower limit for the reference interval is somewhere between these two numbers, and my upper is somewhere between these two numbers. This gives you no assurance on how tight or narrow or wide that bound is. It is not an assurance of we can stably estimate this. It is just saying we can estimate the error in this estimate. On the other side, I could not find, no matter how hard I dug, where that 20 for the verification standard comes from. If someone can, or someone knows, please tell me. I spent an entire afternoon trying. The closest I could come up with was that 20 lines up with 95% really nicely, so 1 in 20 is 5%. Maybe there's a better answer. I cannot find it. And so I don't think this one is also based in any assurance of good verification standards either. And let's talk about why. So let's imagine we're omniscient and we know that Seattle's greater population has a mean platelet count of 300 and a standard deviation of 76, right? So that the true reference interval, because we're God in this scenario, is 150 to 450. Well, let's go do an establishment study. We can take 120 people at random, and this is ignoring the challenges of screening someone for health, which is a big challenge, right? It's very hard to know for sure that someone's actually healthy. But let's take 120 people, pick randomly, and how much will sampling bias affect our estimates? So we can take our distribution, run some sims where we grab some. Sometimes we grab people on a higher end, sometimes on a lower end, and we'll end up with different estimates of that interval. And if we run a simulation, what we get is something like this. This is the spread of upper and lower limits. And what we find is that in 10% of our attempts, where we know what the true answer is, one of those limits is going to be off by 35 or more. You can do a little bit better if you use a parametric method, but that's conditioned on knowing what the distribution of values in your population is, which we don't always know for a lot of tests. And maybe you can say, well, okay, 10%, that's not a high rate, but another way to frame this is, in a big city like Seattle, how many different labs run a CBC or a MET panel that people can get their care at? There are a lot of labs. If your city has 10 labs and they all are operating on the same population and run this study, at least 2 of those labs on average are going to have a limit differing by 40 units for no reason other than random bias and random sampling. And this is, again, under ideal conditions. Well, what about the other side? Let's say, okay, well, our manufacturer, they can afford to get a lot more samples than 120, they can build good reference intervals, and we can just verify it. Okay, so let's take something like hemoglobin. A standard reference range for women for hemoglobin might be something like 11.5 to 15.5. So if we have that reference range, how much can our population vary from that and still pass verification? Well, this is a graph that says, well, on the y-axis is how much our mean can differ. So let's say our mean is 1 unit higher, so instead of 13.5, it's 14.5, or 1 unit lower. And the x-axis is how much our variance will differ, so 50% smaller, 50% larger, so more or less homogeneous population. Well, a third of the time, if your variance is the same but your mean is different, you're not going to detect it. A third of the time. A quarter of the time, our variance could be 50% larger and we wouldn't detect it. We have a much more heterogeneous population and this would pass verification. 10% of the time, even if our populations are identical, verification will fail. This is less of an issue because CAP guidelines say if it fails verification, just collect another 20 and do it again, and if it passes, that's good. So it's actually all right for detecting the true distribution, but it's not good at detecting failures. But the big thing is, if your variance in your population is smaller than the reference population you're using, you're basically never going to detect that. If you're down with a lower variance, you can have really big shifts and everything will just keep falling inside that interval because your population is more narrow than that one. These guidelines are not really established to detect those kind of differences. And we know this as a field. For the last few years, there's been a big rise in the popularity of what's called indirect methods to say, well, okay, it's really hard to collect a lot of samples, so what we can do is take our existing health record databases where we have thousands of patients and we can screen out people with weird concurrent results or based on testing location, and we can identify a dominant distribution and use that as our basis. And that can work, though it does have some problems that I don't have time to get into, but also requires having a pre-existing population of testing, which is not good for new tests. Which is all to say, this has a lot of different problems. But look, maybe you're going to say, well, do these differences really matter? Does it matter if our platelet limit is 150 or 175 or 200? Does that actually affect anything? And I think, firstly, I would argue strongly that yes, it does. There is all sorts of evidence across the literature about threshold effects in medicine, about how clinician behavior is influenced by all sorts of things. One of my favorite studies from, I think, 2023, and I forgot to put the slide in for this, is a study of OBG doctors that showed that if you have a patient that has a C-section and it goes poorly, you are more likely to opt for a live birth for your very next patient, or vice versa. That your decision as a doctor is being influenced by what happened to the past patient in a way that it shouldn't be, that they should be independent. But let's take a lab-based example. This is unpublished data. It's a little bit raw. It's from the last week, so I'm not going to make strong claims on this, but this is the rate of ferritin ordering after a CBC has resulted at UW in outpatient testing. So you order a CBC, but don't order a ferritin at the same time. And after the CBC or the hemoglobin results, how often does the doctor then add on a ferritin? And as you can see, for both men and women, as you approach the reference interval, the dashed line, the ordering starts to skyrocket. Now, you could argue this is not a threshold effect. It's starting to happen a little bit before, etc., which is fair. But at the same time, the likelihood that that ferritin test detects iron deficiency flatlines the second you hit that reference limit, which to me suggests that it's overordering of that test, right? You start to drastically increase order volume, and at the same time, your diagnostic sensitivity flatlines. Because we don't see a flat line when we look at non-ordered testing. So this is from NHANES, National US Health Survey, and where they're ordering the CBC and the ferritin concurrently for all patients because it's a survey, and you see diagnostic sensitivity continues to go up with hemoglobin. Now, this is not perfect data. It's unpublished. It's a little bit raw, so I'm not going to make really strong claims. But I would also add the other side of this, which is if you think these differences don't matter, well, what are we doing establishing and verifying reference intervals at independent medical centers then? Like, check for bias, but why are we spending a lot of time going and collecting samples and doing all this work and having these big guidelines that tell us to do this if we don't think those differences matter? Okay, so that's kind of my angry rant, half of this. And someone can come up and tell me why I'm wrong after that. But I'm going to pivot now. I'm going to talk about the other side of how we can kind of do some other interesting things by looking a bit forward and doing some research. So what can we do about this? Well, I mentioned those 4 big buckets, and I'm going to start briefly mentioning a vignette from the first 2 and then spend a lot of time talking about patient and context specificity. But let's talk about physiologic linking. And a good example for what I mean by this is hemoglobin and iron deficiency. So ferritin is a protein that we use that is involved in iron transfer, so it's used as a primary diagnostic test for iron deficiency, right? We know it has some limitations, it's confounded by inflammation, but it's still our standard test. And if you look at World Health Organization, the guidelines for ferritin for iron deficiency are usually set at around 15. Many institutions use cutoffs of about 10 to 15, including UW, for women. They usually use slightly higher ones for men. And these are all based on broadly established normal ranges. I'm saying broadly because I don't want to claim that the WHO is only looking at a normal range. I didn't actually find good documentation of exactly where that came from. But it's a weird way to look at this given there's such a strong physiologic link here. Because what we really should care about is not just, is the ferritin abnormal, but is the ferritin putting downward pressure on hemoglobin? i.e., is it likely that if we increased your ferritin, that your hemoglobin would increase in turn? Because that's really what we should be caring about from a physiology perspective, not just is it abnormal. Now, there's also non-anemic iron deficiency and things. There's some other considerations. But what we can think about for anemia is, well, here's a bunch of ferritin points, measurements, and concurrent hemoglobin measurements, and we see mostly it's flat in the distribution, and then at some point, we start to see this negative pressure coming down that curve. And so we can try to estimate, well, when does that curve start to kick in? And if you do this a little bit more carefully, you separate out by different age groups, men and women. What you can see here is somewhere, depending on which marker you look at and how much change you care about, somewhere between 20 and 40 nanograms per mil in ferritin is when your heme parameters start to decline. This is work I did as a postdoc, one of the first projects I worked on that got me really interested in lab data from kind of analytics perspective. And recently, in 2025, a group did this at much larger scale across data sets from spanning a lot of different countries and in kind of almost meta-analysis style, except they were each study. They found that the average ferritin point for a hemoglobin decline was about 25 for women, for adult women, excluding people who are pregnant, not 10. And this is good because it means we can justify trying to change guidelines. And actually, the American Society of Hematology just released draft guidelines around this a few months ago that are still open for comment, trying to move the ferritin threshold to 30 because it better reflects what iron deficiency anemia actually means, where a normal range didn't because a large portion of the population has subclinical iron deficiency. Iron deficiency is high prevalence, particularly in women who are menstruating, and so reference intervals aren't capturing that because the screening isn't properly kicking it out. But if you look back to the physiology, we can better capture it. So that's one little vignette. The other is about granularity, about the dangers of kind of binary thinking. Or not even the dangers, the value of not thinking binary about data, thinking in more continuous ways. So I'm not going to talk about something that's exactly a reference interval, but something that falls in the same sort of vein, which is peripheral blood microscopy or blood smears. So take a drop of blood, spread it on a pane of glass, look at it through a microscope. A hematopathologist comes and looks at it. And if you look at a lot of guidelines or how a lot of hospitals operate, when they're evaluating, say, red cell abnormalities, they'll come in and just try to say, are abnormalities present or not? Are there sickle cells or not? Or sometimes hospitals for some cell types will have guidelines that say, estimate a rough density, 1+, 2+, 3+. It drove me mad that at Mass General Hospital, they had different guidelines for this for different cell types, and nowhere did they actually define what 1+, 2+, or 3+ meant beyond just a few, a medium amount, a lot. Well, the problem with that is you're then kind of training yourself to just think present or not, and it makes it hard to meaningfully capture, well, if I give someone a treatment, are the cell densities going down? Are they going up? Are they responding? Things like that. So I got to work on this great project looking at using computer vision to actually just do cell counting, to go, well, let's actually just directly count the cells, a thing that a hematopathologist just doesn't have time to do at the depth that you would need to, and then showing that we can make better diagnostics. We can make more sensitive diagnostics, say, for thrombotic microangiopathies by looking at actual cell counts. And we got to a really cool case of being able to deploy this in the wild in a rare case of someone with thrombotic thrombocytopenic purpura who was not responding to traditional plasma exchange treatments and got sympathetic use of recombinant atom TS13, which is a drug, synthetic atom TS13, making its way through clinical trials. And we were able to use this tool to actually track her schistocyte levels in real time to help inform understanding of whether the treatment was actually working, which is very, very cool. And that got published in NEJM 2 years ago. So that's kind of on the granularity, just to say that if we look at data more continuously, we can get more insights. And I say that with full understanding that doctors do look at data continuously, but having systems around that flag things and try to push us to binary, I think can be tricky or dangerous. Okay, so after a lot of interlude there, this is the thing I actually want to spend the time talking about, which is patient and context specificity. Because what I mean by this is, well, you show up to the ER and your white cell count is 11,000 per microliter. Well, that's not really telling us one thing. It's telling us three things simultaneously. There's a genetic component, or a gene-environment early-stage interaction, saying that your body achieves homeostasis and regulates it in a certain way. There's an acquired component. Hey, you have rheumatoid arthritis, and that's not healthy for you, but it's a chronic condition, we're not curing it, and it's putting upward inflammatory pressure, causing a rise in your white cell count or other inflammatory markers. And there's a short term. You've been hit by a bus. Your body's panicking because, hey, you've just been hit by a bus. And look, we're measuring those three things simultaneously, and ideally we want to separate them out because, hey, the genetic part, that's informing screening and long-term modifications. The acquired part is about chronic treatment and just understanding what healthy means as you age, because normal is not a static concept. And then the short term is triage and detection and diagnosis and immediate treatment. And so ideally, what I want to think about is, particularly for these common tests like blood counts and metabolic panels and the bread and butter stuff, how we can better separate those factors out. So let's start with the context specificity. So this handsome fellow is Aaron Aguirre. He's a cardiologist at Mass General Hospital, and he basically only looks at patients in the first, say, 3 to 4 days post cardiac surgery, so bypass grafts and valve replacements. And I remember talking to him one day, and he described it as if the chart is just screaming at me at all times, because he opens up their chart and half of their markers for any given test are through the roof or off the floor because, hey, this patient's bad, they're anemic, they're inflamed, etc. And he goes, I know, they just had their chest cut open, they had blood run external to their body, their heart stopped. Of course they're in a bad state, it's been 24 hours. I'm not trying to say, do they look like someone off the street? I'm trying to say, do they look good for a cardiac bypass patient? Do they look like the patient who 24, 48 hours from now is going to go home, recover fine? Or do they look like the person who has internal bleeding that we're not going to pick up for 3 days and then they're going to crash? What does healthy mean if you've just had your chest cut open in the context of this massive perturbation? And a way we can think about this is things like nomograms. We can define what normal is for a given marker for a given patient. And I did this big study, we looked at things like that, and one of the things we found from doing a lot of analysis that I don't unfortunately have time to go fully in depth is you can also look at nomograms for multiple markers simultaneously. So this is a nomogram effect, or the average healthy trajectory for white cell counts and platelet counts simultaneously for people who did well, meaning they didn't die, they discharged within a week, and they didn't come back. And what you can see is you start with, say, a high platelet count and a low white cell count. The surgery perturbs that out, and then over the week, from day 0 through to day 7, you slowly recover back, right? So you form this hysteresis loop. And the cool thing is, that hysteresis loop is functionally the same across ages. So 80-year-olds and 50-year-olds who do well all have the same sort of average response. It's the same across different lengths of stay, provided that length of stay is short enough to not be a bad sign that something terrible happened. It's the same across different centres, so Mass General Brigham and Brigham and Women's Hospital. I've also confirmed this is the same at UW and at other hospitals. It's the same across different kind of starting. If your platelet count is higher than average, you still follow that hysteresis loop, etc. And if we stratify people by their preoperative risk evaluations, because the Society of Thoracic Surgeons has a great pre-op risk calculator, conditioned on the patients doing well, the average response of that hysteresis loop is the same. And it's the same across different surgery types within the cardiac space. So aortic valve replacements, cardiac bypass grafts, etc. Why is that important? Well, it means we have a stable benchmark for what normal is for those two markers over time. And it's not just a benchmark for this hyper-specific, okay, you are 73 years old and you've had this exact surgery in this exact conditions. It's a general benchmark of just cardiac surgery. And if you take that benchmark and you look at just, well, where is a patient relative to that? Is their platelet count lower? Is their white cell count higher? And are they moving in the same direction as that curve? Because we can think about this dynamically as well. Well, that's associated with 10 or 20-fold risk stratification for outcomes. So if you're in the worst 10% for either for the direction you're heading in, say the direction being that kind of the various points you can shoot off, you are 10 or 20 times more likely to die. Or if we map out direction and position simultaneously, you get really large risk stratifications. And a big thing here is that it's not just where you are that matters, it is the direction you're heading. They both contribute independently to risk. If you're in a good position but heading in a bad direction, that is about as bad as being in a bad position heading in a good direction. And some spaces of medicine do think a bit this way, right? If you go talk to a pediatrician, pediatricians have to think in nomograms because physiology changes so fast in kids. Well, if they've got two kids and they look at their weight percentiles and one's in the 75th and one's in the 10th percentile for weight, and a year later, one is still in the 10th percentile and the other is now in the 50th percentile, they'd be a little bit more worried about the kid who's dropped from the 75th to the 50th than the kid who stayed in the 10th. One is just small for their age, one is declining and is on a bad trajectory. So we do know a little bit about this. The cool thing is, and I'm going to have to skip some of the details here, but this isn't just true for cardiac surgery. Turns out with some normalization, which just means kind of accounting for the fact that different types of surgeries or different inflammatory events invoke different inflammatory style bursts. A cardiac surgery is much harder on you physically than a hip replacement typically. Or a laparoscopic surgery is very different to a thoracic open chest surgery. But we see very similar dynamics across these different surgery types. The same sort of inflammatory response, the same kind of blood cell dynamics, and the same sorts of risk stratification. And the way I would think about this is that there is no evolutionary basis for a sterile wound. The body has no idea, no way to know the concept that you are getting kind of cut open in a way that doesn't bring in huge infection risk. So it's going to panic for a lot of things in identical ways because it has the same sorts of triggers it can throw. I shouldn't say identical, there will be little differences, there will be differences per thing, but there are broad phenotypes that are the same. And that's really valuable because again, it means we don't have to create the hyper-specific benchmark for every individual unique setting that the hospital or a patient can go through. We can create broad categories of phenotypes to say, hey, this is what inflammatory recovery looks like. This is what broad cancer trajectories look like, things like that. Okay, final thing I want to delve into is patient specificity. Because I think this is the one that I think is my deep love in the research space. So this is a Manhattan plot of a genome-wide association study for hemoglobin. So what you can see from this is hemoglobin has fingerprints up and down the genome, right? It is polygenically regulated, and it is a very fundamental human trait. And so it is influenced by all sorts of parts of the genome. It has twin study heritability of about 50–55%, which isn't quite as high as, say, something like height, 80%, but is up there as one of the most physiologically regulated traits. And it turns out if you take the 50 most common laboratory test markers, so your CBC, your MET panel, liver function test, thyroid stimulating hormone, PSA, I'd say about 40 to 45 of them have heritabilities above 30%. What does that look like in data? Well, if we take, say, platelet count and we take outpatient platelet count testing over 20 years, this is what it looks like. You can see the black is just 500 or 1,000 patients, and on average you have this population level variance, right, which is our population reference interval. But within that, most patients are regulating much more tightly. So you have this yellow patient who has a high platelet count, and unfortunately their platelet count's going to have to drop further before it gets picked up by some doctors and some systems, and it means they might be in a worse state when it does get detected. And that blue patient, they're going to have a lifetime of unnecessary workups because they keep regulating inside and outside the reference interval. And to briefly say that this is held over even in the context of extreme physiologic disruptions. So this is, I'm noticing I maybe trimmed the dates. This is over about 10 years on the bottom. There are dates missing, but it is there. This is someone with thrombotic thrombocytopenic purpura who keeps having recurrent issues of it, recurrent episodes. And when they have really bad episodes, their peripheral platelet population nearly gets fully depleted. They go down to platelet counts of 2 and 3 and 4. And they keep doing this every couple of years. And despite that, most of the time, when they're not in these severe episodes, their platelet count is staying between 180 and about 310. And the population interval, this was at Mass General, the population interval there was 150 to 450. So even in the most severe cases where the cell population is being peripherally wiped out repeatedly over decades, they are still regulating at half the variance of the population interval. And this has real clinical consequences, really meaningful ones. One of my favorite studies from 2024 is a group from Atlanta who looked at patients with a genetic predisposition to a low white cell count. So they used a biobank, calculated polygenic risk scores, stratified patients by their white cell count polygenic risk score. And what they found is if you had a genetic predisposition to a low white cell count, you are more likely to get bone marrow biopsies, more likely to have those biopsies come back negative. So you were getting expensive, harmful, and scary as hell testing unnecessarily at higher rates. And on top of that, for the patients who did end up having the cancers, when they were treated, the treatments were less effective. So they had increased risk of having to discontinue immunosuppression or increased risks of leukopenia, because again, they're being treated against a population standard. Okay, so if it's a problem, what can we do about it? Well, I think there's a few different ways. One of the great things now is that we have a lot of data on the average patient. People in the US particularly go to yearly physicals. A lot of doctors are pretty trigger happy with blood testing, and so we get a lot of testing. All of it's a little bit biased, but we have some data. And so if you're a talented grad student in my lab, like Cindy Zhang, what you can do is build something like a Bayesian inference framework, which I'm not going to go through the math, but all this means is start by assuming that someone is somewhere inside the population reference interval at random, and every time you get an outpatient test, hone in that estimate a little bit. Get a little bit narrower until you've worked out what is normal for them, what is normal variation for them. And if you do that over thousands of patients, you can find that the set point, the value they're regulating around, and the variance, the coefficient of variation, aren't super related. You can have a low set point and high homeostatic control, or a high set point and low homeostatic control, or vice versa. And importantly, you can estimate the set point pretty accurately with only a single data point. Basically, if I go take your platelet count and it's 300, well, maybe your set point is actually 350 or it's actually 250. It's probably not 200, or it's probably not 400. Does take a little longer to estimate variance because variance is about variation, so you need multiple data points, but you can still hone in. So why should we care about this? Well, a couple of reasons. Firstly, set points themselves are prognostic. So if you have a high white cell count, and this is all limited to things within the population range, so let's say you have a white cell count of 9 and I have a white cell count of 5, and we're the same age and sex. Well, you are twice as likely to die in the next 10 years, all-cause reasons, than I am. Just because your body's regulating in a certain way doesn't mean it's a good thing. What is normal for you isn't necessarily what's healthy for you. Similarly, if you have poor homeostatic control, so a higher coefficient of variation, that is a risk signal, generally for mortality. And it's also risk signals for lots of specific diseases. This is 6 examples. I could pull about 300 because it turns out lab markers are associated with disease. This is not meaning super, super different from a single marker, but it's a stronger signal. And so I'd point out something like myelodysplastic syndrome. If you have a chronically lower red cell count, well, that probably speaks to maybe some extra clonality in your hematopoietic stem cell population, which might be a signal that you either have undiagnosed CHIP, clonal hematopoietic mutations of indeterminate potential, or that you are on the pathway to developing a myeloid neoplasm. So these are prognostic themselves, but I think the more exciting thing is it can help us interpret new tests. So let's say this is data from UW, I think. It's either data from Mass General or UW, and we've replicated it in the other, and I can't remember which one's up here. But this is patients who got ferritin and hemoglobin tests simultaneously. And if we stratify them by the presenting hemoglobin and by the change in the set point from, say, a year ago to that point in time, well, the positivity rate of the test for iron deficiency is not just a function of your presenting hemoglobin, it's a function of how much you've dropped. Makes sense, again, the physiologic signal. It also speaks to better lab test utilization of why are we testing ferritin in people with hemoglobins, say men with hemoglobins above 13.5 who have been at the same hemoglobin level for years. We probably shouldn't be running those tests. But the other side is we can also look at treatment decisions. So this is new but unpublished data, partly from Cindy, also from a collaborator, Barbara Lamb, who's in hematology at UW, looking at patients with iron infusion. So we take everyone who got an iron infusion, we look at the hemoglobin from like the week prior to infusion, we look at their set point from a year prior to infusion, and we look at their hemoglobin 4 months after infusion. And what we find is, hey, the presenting hemoglobin is correlated to the response. If you have a low hemoglobin, you're more likely to have a hemoglobin increase after infusion. But it's much, much more strongly correlated to how much you dropped from your set point. Basically, even if you have a low hemoglobin, if you had a low hemoglobin a year ago, the chances that the iron infusion is actually going to kick off a response are much lower. And this is preliminary, but I'm hoping that we can build this into actually potentially informing decisions like this to say, well, hey, is an iron infusion likely to work? And I say this knowing there are multiple complex reasons. I'm skipping over some of the complexity of clinical medicine. I know that. I'm not going to stand here and say that I know better, but I know there's more complexity here. But I still think we can use some of this in really powerful ways. So we're nearly at time, so I'm just going to wrap up by talking about where we're going. So I've only been at UW for 2 years, so this is still very much me nursing my babies through the toddler phase into the point that they can run. And so when I think about the translational pathways, these are all works in progress, but these are some of the threads we're pulling at. So I've talked about iron deficiency and iron infusion, and one of the ways we're actually moving forward with that is doing some prospective testing. So right now we're running a study where every day we check for patients who show up to outpatient clinics at UW who have a hemoglobin drop from their pre-estimated set point and who don't get a ferritin test. We are coordinating with the UW Research Testing Service to prospectively grab a ferritin test, to use the excess remnant blood specimen to prospectively collect ferritin tests. We're probably about 2 months away from having the actual data, enough data from that study to analyze, but we're hoping that we can show that looking at the drop from set point can actually more sensitively diagnose iron deficiency, because if it can, we can then look at piloting, say, an EHR auto alert tool that says, okay, you ordered a CBC, it's resulted, you didn't order a ferritin test, but hey, they did drop a fair bit from a year ago, maybe you want to consider that. Or conversely, the opposite tool to be like, are you sure you need this test because it's probably going to come back negative? So the pathways of that, simple things where you can just do nudges as opposed to trying to end-to-end. We've got some great collaborative work with Colin Pritchard, who I think was here but had to leave, and Bertu Dast, who's at the Fred Hutch, looking at PSA set points to see. PSA has all sorts of challenges with diagnostic sensitivity. We're trying to see if integrating set points can help with that. I've been working with Fabian Lucas, another DLMP member, on looking at can we use some of this data to better predict CAR-T therapy responses, looking at screening for myeloid neoplasms, looking at pregnancy outcomes. And another big one I haven't gotten to touch on in this talk is looking at resource-limited settings. So I have some great collaborations with Carl Brito here from, he's at Boston Children's Hospital, but also works with Cloud Physician, a distributed telehealth ICU set up across India, looking at how you give better ICU care in really resource-limited settings where you don't have as much data. You don't have as much ability to run complex tests, so you have to make sure you get every drop out of the more simple tests. And I think that's a really, really exciting pathway as well. And we recently got some funding from the Gates Foundation to start digging at some of those problems more, which is super exciting. And final one I'll mention is from Dr. Mina Rafiq, who's at University College London, who is a kind of affiliate member of the lab now. She's done some great work prior to being connected to the lab, looking at outpatient CBCs and other routine tests. What happens if you take those and instead of just looking, are they abnormal, you combine it with non-generic symptoms. With generic symptoms. So I have an abnormal platelet count, and also I have some abdominal bloating, or I've been having weird pain. Because it turns out that shifts your prior from everything's fine to maybe there is something wrong. And she's been looking at that in context of cancer diagnoses to say, well, it turns out if you have a generic symptom and a lab abnormality, for some labs that can increase the risk that you develop cancer in the next year by 4 or 5-fold. And that's really valuable, particularly in the context of the UK, with a nationalised health service that has guidelines that say if anything increases your 1-year cancer risk above 3%, that is, their recommendation is that you get referred onto a cancer clinic. So that is part of guidelines. We're looking and collaborating to see if set points integration into that can actually inform cancer guidelines in the UK to improve screening there, which is such a great avenue for application of this. And she's just shared some recent work yesterday that I didn't feel quite confident enough to put up on slide, but shows that maybe this has some legs. Okay, so I've talked a lot. You've listened to me patiently or fell asleep, but to wrap it all up, I always end with a little vignette, which is that beautiful, wonderful you somewhere in the audience, I hate to break it to you, something terrible is going to happen to you. You are going to have a car crash or a heart attack or a stroke, or you're going to get a severe infection. And I am so deeply sorry about that. If it makes you feel any better, it's going to happen to me too. No one gets out alive. But one of the big challenges that we do face is that by the time you show up at the ER, in the ambulance, to the emergency, to ICU, etc., your body is in the thick of it. It is fighting the good fight. It is inflamed. It is already at all alarms. And we don't really have a good way to separate that out right now. And my hope, my long-term goal for what I'm trying to do here is, well, we have a bunch of testing on you because you've been getting care through the Epic system or through Seattle, etc. We have Care Everywhere to share some notes and things like that. And maybe we can take that and separate out what is normal for you. And hey, we know what normal for being hit by a car is because we have plenty of patients in our health record databases who have unfortunately been hit by cars. So we know what normal is for that. And we can use both of those collectively to separate out these effects. That is the long-term vision. We are not there yet, but that is what I spend my days and nights thinking about. Okay, So I will wrap up by saying a big thank you. Research always takes a village. I've been part of many great ones, in particular my lab, a few of who are here. There's some other great people who aren't in the room but are wonderful. Some of this work was also done as a postdoc at Mass General and Harvard Med under the supervision of John Higgins, who is one of the world's most delightful people. And to thank a few funders that I had some pilot funding from the NCI, from the Gates Foundation, have been very, very well supported by the Brotman Beatty, who's taking a good bet on a young PI, which is lovely. And then things like the UW DLMP Martin Reichenbach Award, which is very lovely, those pilot grants to get some stuff off the ground. And then finally to say that we are actually in the middle of hiring 2 postdocs. So if you know someone who is data-driven and obsessed with lab medicine, please put them in touch. But otherwise, a deep thank you to everyone for listening to my rambles.
Thank you so much. I don't have much of a question, but rather some thoughts about everything you said. It seems that what you're proposing is something more of moving from diagnostics to prognostics, right? Giving to prognostication in terms of gathering data and giving this kind of tridimensional approach and doing something different to say, this is normal because this is expected or something. And then based on that, make decisions. So it's probably my question is, well, 2 questions. Number 1, is it your plan, for instance, to use all these data analysis and put it in and feed algorithms that at the end of the day will tell you what is the prognosis for these patients? For instance, as you were saying, if you go this route, your chances of survival are this or that. And if you go this route, your chances of survival is this or that. Like, for instance, for sepsis, right? If you're in this curve, you're about to die. But if you're in this part of the curve, you're going to survive. So that's number 1 question. And then the second question is, I'm very, very interested in everything you show in respect to transfusion medicine, right? Like, we change all these parameters with transfusions, and we know that there are also, I think you can see where I'm going, right? So if you have time, let's talk.
Yeah. So to re-emphasize, so the first one was kind of talking about like the kind of prognostic nature of the work, and is the goal to like have these complex algorithms, and I think I actually don't think of the work as pure prognostic. I actually think the best avenues, particularly for the personalized reference range stuff, is actually very much in the diagnostic belt to go, can we identify in advance whether a given clinical workup is going to be necessary or not? So, hey, don't do the bone marrow biopsy because it turns out they just have a genetic predisposition to a low white cell count. Save the time, save the money, save the stress. Or conversely, hey, run the iron studies so that you can detect iron deficiency and you can give them iron supplements and correct their thing. So I think there is actually very good diagnostic, though I think prognostic is also part. We have some good studies going on right now looking at, say, the development of chip mutations into myeloid neoplasms, and can we detect that early. So I think there is both. In terms of the algorithmic side, I actually think a big motivation for a lot of this work is that it doesn't need to go down the end to end, chuck it all into a black box and have it spit out an answer for you. Like, the whole point is, okay, we can use some complex modeling to work out, say, what is normal for you or what is normal for this scenario, but at the end of the day, we're still just giving you like a range to compare the white cell count to. It's completely and utterly interpretable. It is very physiologically grounded in a way that a lot of machine learning kind of leaves that realm, and it means the avenues for deployment, I think, are a lot more straightforward. That is kind of the goal, and then to maybe have like alert systems that can connect to that or other things, so being aware of alert fatigue and all that. On the transfusion medicine side, would love to chat more. One of the things that has kept me at a somewhat arm's distance from transfusion is always the 2 challenges, is that we don't always know the parameters of the blood that's being put into the patient, and I wish we did, and that would make a lot of this a lot easier. It's a lot harder to reduce the confounding if, say, you don't know the MCV of the blood that was just put into the patient. The second is and I would love to maybe chat later about your thoughts on this, but how you work out if a transfusion was necessary or not. Because it's often easy to work out when it should have happened and didn't. Say the patient crashes, bad things happen, but you unnecessarily give a patient a transfusion that didn't need one. Oftentimes their body will handle it, right? They'll clear the cells and they'll be fine. And that's really hard to study around because it's just Personally, I've stayed clear because I don't know a good answer to that question. If you or someone you know does, please, I would love to chat.
Let's talk. Yeah, let's talk.
Sorry. Go ahead. Yeah, Maria. So like thinking about like some of these trends, like, oh, if we had this person's trend previously, we could kind of see where their natural set point is. Like that, those kind of conversations, just anecdotally, I think that a lot of clinicians are kind of thinking that, like, you kind of eyeballing it, like, oh, maybe it's just low because that's where they live. But we're kind of saying it in like a hand wavy kind of way. And I just like, is there any mechanism to compare the output of some of these algorithms with like clinical adjudication to just see like how good are we at predicting some of these things when we're hand waving, or are we just like terrible at it?
Yeah, that's a great question, and I will like, I definitely always want to echo that I think a lot of these things are they're not like. The good doctors are thinking about this stuff, and I would make the tongue-in-cheek that every doctor likes to think they're the good doctor, and not the bottom of the med class. But I've seen enough weird stuff in this when I've dug at data over the years. Like this is not quite reference interval, but from blood smears, I remember looking at a few cases where someone just kept repeatedly being called as sickle cell positive, and you would look at their smears and there's not a single sickle cell on them. There's nothing that could even be remotely considered a sickle cell, but they were black, and so the doctor, I think, or maybe they had one 10 years ago, and so the doctor would not even look at the smear and just keep calling it. So you get things like that on one side. In terms of how you prospectively study, I think there are two things. One is you do things like using excess clinical specimens to run tests that are freed from clinical confounding of the doctor thought this was important to order, which can help understand some of that. Or obviously clinical trials being the more strong version of going down that path, but that's a lot more, you want to have a lot more confidence that your idea is good. I would love to study clinical decision making. The problem is I've found that, at least when I've talked to clinicians, they are very hesitant to kind of put themselves on the line that way, and because clinical decision making is very complex and very multifactorial. And so it is very hard to get a good study design that can kind of appropriately guardrail. Not impossible, it seems like a hard problem that has just not been one of the ones I've decided to pursue.
Yes, again, thank you for such a nice talk. I think the public will be very interested as patients are getting their own results and following them over time. I think this has a lot of appeal, not only to physicians and medical centers, but to individuals who are getting those results and often come back to their providers and say, my whatever changed by this much, tell me about it. So, but another question I have for you is, I think you've been focusing on reference intervals. And I think another statistical approach would be looking at likelihood ratios and saying, well, I don't really care that much about what my reference range is, but I know wherever I am in that range, things change and their likelihood of a particular diagnosis or condition makes a difference. Would you combine those, or what do you think about the relative value of looking at two approaches?
It's a good question. And to the first point, a regular occurrence I have when I talk about my work in kind of at parties or to colleagues and friends. A statistician came up to me at a party, because I go to those kind of parties, I guess, and was talking, and I'd said I work in like research and blood testing, and he just turned to me and said, I've had a question that's been bugging me for 10 years. Those normal ranges, they can't actually know that with any accuracy, can they? So I do get those. But a common thing I get when I talk to more general population about this is people echoing the story of like, I have had a low white cell count my entire life, and every time I change provider, I have to have this long, extensive conversation with them to echo what I know, which is, I'm fine. Like, I've had this for 20 or 30 or 40 years. And so definitely I have had many, many different echoes from patients about their experience kind of qualitatively with that. In terms of the other stuff, a thing I will say is, like, I'm not the first person to come up with this idea or anything like that. This is building on a lot of people who've been playing in this space. And people have proposed things like likelihood ratios, which I actually think is a really good standard to pull it back towards diagnosis and prognosis. I am choosing to approach it this way because I am choosing to play within the system as is a little bit, and to go, well, okay, these are the standards for better and for worse. For all the limitations they have, this is the current standard that we have across everywhere. And I don't want to approach it from a burn it all down perspective and propose the Brody-Foy standard that will never fail. I want to find targeted use cases where we can really justify an alternate framework for a key clinical decision. It is why I'm taking my time building out, because I want to make sure the first 1 or 2 cases that we lead with, whether it's something like iron deficiency reflex testing or thyroid stimulating hormone or whatever, I want to make sure they really work, because I want to really make sure we lead with our best foot on this. And like, maybe if I'm very successful in 10 years, we can argue about, well, can we really just justify broader changes? But I think you have to first start with targeted use cases. And I think for me, I think the best way to go about that is playing within the system, within the structure that we have, which is reference intervals.
Speak one more time.